Campylobacter. This is going to be one of the most common causes of diarrhea in the U.S. I mean, you look at the symptoms. Okay, frequent watery stools. Okay, it's no blood. It's not you're not. They're not passing so much diarrhea that it's now running clear. There's going to be a slight fever, vomiting, headaches, abdominal pain, and it could last for a few weeks. Campylobacter jejuni is the most common species causing this. Okay, there are other species within the Campylobacter genus that can cause disease, but they are not as prevalent in us humans. You'll see them in other mammals. You go through, look at the characteristics. It has a slight curved, almost comma shape. Or it could be, if it's in the process of division, could be almost a spiral, gram-negative bacteria. It is highly flagellated, has flagella at both ends, so it is highly motile. Okay. They are microaerophiles. They like the low oxygen environment in the intestinal tract. They can also be seen spreading to the genital urinary tract, depending upon personal hygiene. And nowadays, with changes in sexual behavior, we can also see that Campylobacter jejuni has been traced to oral cavity of some people. Okay, how it gets from the large intestine to the oral cavity, or the genital urinary system to the oral cavity, I will let you figure that out on your own. Ask your mom. She can explain the birds and the bees to you better than I can. Transmission generally, though, is going to be ingestion of something that has been contaminated. Food, water, being contaminated with Campylobacter jejuni. So again, think of this as a fecal oral route. Campylobacter will pass through most of the gastrointestinal tract until it hits the end of the small intestine. Okay, right where it's going to meet up with the large intestine. That is where Campylobacter likes to colonize. It adheres and it burrows through the mucus and the mucus membrane, the epithelial lining at that juncture. One of the things we haven't discussed yet in any of these mini lectures has been incubation periods. Okay, incubation period for Campylobacter is going to be 1 to 7 days. If it's an intoxicant, some of the other things that we've talked about and things that we will be talking about, you're going to see that the incubation period could be anywhere from a half an hour to, a week or so. Campylobacter also has been shown to make a heat labile enterotoxin. Okay. This enterotoxin they say it stimulates the mucosa. What it stimulates the mucosa to do is ramp up cyclic AMP production, which triggers the cells lining the large intestine to, instead of pulling water from the lumen, from any of the food that's passing by, to reverse the waterworks. Absorb water from the surrounding tissues and then excrete it out into the lumen of the large intestine. Heat labile. If it's heat labile, it means it can be damaged when heated. Heat stable. If you see anything that says heat stable, that means you can heat whatever it is, foods or water or liquids, up hot enough to kill the bacterial cells, but the toxin will remain stable. Heat labile gets damaged just as quickly as the cells get killed. Some people who are suffering from Campylobacter jejuni induced acute diarrhea can also progress to what is referred to as Guillain-Barré syndrome, GBS. The toxin goes toxemia. They start showing signs of being septic, and there is some damage at the neuromuscular junctures, meaning that they're going to lose the ability to signal for contraction. So it's going to be a limp paralysis. If it's a mild case, okay, they're not showing any signs of developing Guillain-Barré or anything like that. They're not, excreting out extreme amounts, during, of fluids in the due to diarrhea. Non-specific rehydration, saline, get their electrolyte balance back into where it needs to be, which may mean, here's a salt pill, here's, potassium pill, or you may just put it into the saline drip and let them get it that way. If the patient is having major issues, it just will not go away. They're now past that, couple of weeks period, or they have some underlying clinical issue. They're already immunocompromised, or they have some, they're already sick with something else, come in with erythromycin or azithromycin. But again, you want to minimize antibiotic treatment as much as possible, because it could lead to removal of the normal flora, removal of the competition, and then you get Campylobacter or some other opportunistic pathogen will then overgrow, and the patient's problems just get compounded even further.